Everyone, I'm Jennifer Bright. I'm the president and CEO of iChom. Welcome to I think it's our fourth in our webinar series this year. We are super excited to welcome you back if you have been to our webinar series since the beginning of the year. If this is your first webinar, get ready for a really interesting and engaging conversation. I want to just share a little bit about some things that are going on at iChom before I hand off to my colleagues and our wonderful presenters today. Just a bit of housekeeping. If you come on board, introduce yourselves and from where you're joining us in the chat. All of the questions that you would like to present for discussion among our panelists, please use the Q&A function at the bottom of your screen. We will not be holding live Q&A, that we will be using the Q&A function. And we will do our darndest to make sure we address all of your questions. Anything that we don't get to live, we will do follow-up. And this entire webinar is being recorded and will be posted very shortly on our YouTube channel, much like the other prior webinars. So we're really happy to hear and to have you with us today. We cannot believe that we're at the end of the first quarter of 2025. There is many things going on at iChom, including the development of a number of new sets, launching our accreditation program. Our iChom education program is starting its second cohort. So we're very excited by all the activity. One of the biggest things that you may be interested in knowing about is our annual conference. And Christine, if you can go to that slide just briefly. Well, not that one. Yeah. So registration's open, if you didn't know, for our conference, which will be 29 September through the 1st of October in Dublin this year. There's lots of new exciting aspects to our conference this year, and we expect to be putting up the agenda on our website imminently, so watch for that. And we look forward to welcoming you to Dublin. So with that, I would love to introduce my colleague, Christina Nielsen, who will be hosting and moderating today's panel. So with that, Christina, please take it away.
Thank you so much, Jennifer. Welcome, everyone. Thank you so much for joining our webinar today. As Jennifer said, my name is Christina Nielsen. I am one of the project managers on our Outcomes Research and Development team here at iChom. So I work very closely with all of our sets. I'll be going into a little bit of detail about some of those. And if you have any questions about our sets or some of the projects that Jennifer mentioned, please feel free to reach out to me. My email is listed on the slide here, or get in touch with anyone else on the iChom team. So without further ado, I would like to just briefly introduce the Hospital de Moinhos de Vento. I know the team that we have here on our panel today is going to go into a lot more detail about their organization and the really incredible work that they've been doing. But first, just as a quick introduction to them, the Hospital Moinhos de Vento is one of our iChom knowledge partners, and they are also the winner of the 2024 iChom NEJM Catalyst Implementation Prize. They won this for their abstract entitled 7 Years Experience of iChom Standard Set Implementation and Outcomes Measurement. So a huge congratulations to the team and all of their work on that. In this abstract, you can learn a little bit more about their experience. The Hospital Moinhos de Vento is a leading institution in a national implementation program in Brazil. And over the past 7 years, they've been implementing 10 of the different iChom sets. And you can see here on the bottom of this slide, the wide range that those sets include across several of our different iChom families of sets, from oncology, cardiometabolic, musculoskeletal, maternal and child health, infectious disease, and renal and urogenital sets as well. And just to briefly mention, in addition to all of the implementation efforts that they've completed with all of these different iChom sets, experts from the Hospital Moinhos de Vento also contributed to developing the iChom COVID-19 set. So that was really a great opportunity for us to work more closely with them as well. So the Hospital Moinhos de Vento started off with focusing on 4 key ICHOM sets that you can see listed here: breast cancer, prostate cancer, heart failure, and stroke. And I know the images are a little bit small here, but this really just shows the breadth of all of the different outcomes that are encompassed just in these 4 sets, not to mention the additional 6 sets that they've also implemented. They have different outcomes domains from survival and disease control, acute complications, patient-reported health status. And these sets alone encompass 14 different PROM tools. So these include things such as the PROMIS Global Health, the PHQ-2. We have cancer quality of life questionnaires in there, self-administered comorbidities questionnaire. So this just kind of gives you an idea of the true breadth of work that was put into this implementation program, and really kind of emphasizes the focus on outcomes measurement that is truly important to patients and people with lived experience of these different disease areas. So if you would like to learn more about these sets listed here or any of the other sets that we speak about today, please scan the QR code that's listed on this slide. You can learn more information via the materials on our website. Or again, please feel free to get in contact with me or anyone else on the ICHOM team. So I will hand over to Arthur first to begin introducing the incredible team that we have here with us today.
Perfect. Thank you, Christina. So hi, everyone. My name is Arthur, and I'm an attending neurologist here at Hospital Moinhos de Vento, and I also coordinate the value management officer here alongside Dr. Nazi. So I would like to call him for the presentation. And we strongly encourage you to send our questions and in the question box so we can answer them in the end of the panel. Thank you. Nazi, please.
Hello, everybody. Good morning. Thank you for the invitation and the pleasure to introduce our experience in ICHOM implementation and how in our hospital after that began more or less 10 years ago. I would like to show you a little history how this started and what is the steps that we follow to create the ICHOM program and our value-based care office. Okay. Can you show the first slide, please, Arthur?
I think that maybe Sheila can introduce herself, then Carisi and Mohammed, and afterwards I will start the presentation.
Okay.
Oh, hi everyone. I'm Sheila Martins. I'm neurologist, head of neurology of Hospital Moinhos de Vento, and it's a great pleasure to be here today to talk about our implementation process.
Hi, my name is Carisi Polanczyk. I'm a cardiologist. I've been working with ICHOM, I guess, since the beginning as Sheila, and I'm Chief of Cardiology Service here at HMV.
Hi, my name is Mohammed Pahini. I'm the CEO of Hospital Moinhos de Vento, and I am an economist. It's a pleasure to be here.
Perfect. I'll share my screen now. Can you see my screen?
Okay.
Perfect.
Okay. So I start my presentation with this picture. We are a German hospital, and in 2 years we've find 1 century of history, and this one has one of the most important hospital in Brazil. And this is a interesting history because our hospital was building during the Second War with German support. And during the Second War, the construction of our hospital, the buildings were stopped. And during this period, next slide, please. And during this period, Arthur, the next. And during this picture, during almost 1 century, we arrived today. The main building, can you see, in the center of the picture was the original building of our institution. And during this period of the Second War, as you can see here, you can show the main building. And during the period of Second War, this is the area where the workers stopped the building to construct the building, and they start our bosque. As you can see, this is a grove, and we have here a great attraction for the patients because it's a nice bosque with some hairy plants. Okay, next one. We are one of the 6 hospitals of excellence in Brazil, offering clinical and surgical care, including liver and kidney transplant programs. Next one. We are a private philanthropic non-profit institution. The next one. And we are choosing one of the 6 most important hospitals in Brazil, and we are a member of PROAD SUS. PROAD SUS is a program to support the development and execution of projects for the unified health system linked to the Ministry of Health. We have many projects that we send and to participate and to divide with the health minister, and innovation in health public, and some new practice and new strategies to improve our public health system. Next. During the last 10 years, we became a teaching hospital. So we have 27 medical specialties, more than 3,800 physicians, and we have a big residence programs. We have also fellowship programs, and we have more than 500 beds in our institution, including a strong group of intensive care physicians that work in more than 90 beds in critical care. We have almost 500,000 of employers. Next. The ranking nowadays, in this week, in this year, we are classified at the 4th hospital in Brazil by the World Best Hospital of Newsweek, and 127th hospital of the world. We are the only hospital at the south of Brazil, and other 5 hospitals, other 3 or 5 hospitals are located around São Paulo city. So we are a hospital very representative of the quality and the complexity of the main hospitals in Brazil. Next one. In the last 10 years, we invested in the internationalization of our institution, okay? We have many partners in many parts of the world, in Asia and North America, Canada, Europe, that because this start to implement our internationalization practice, our complexity, and also the strong fellowship programs that we established as the new group of young doctors that we are that became the members of our institution to develop new areas advanced in medicine. Okay. The next one. So why ICHO at HMV? This is an important question when we started this program to implement the ICHO in our institution. We need to measure the quality of medical practice and the strategic areas defined by the institution. This is the start of a program that unify the many doctors that will work in this hospital. The second, we need to add an international outcome assessment metric based on patient perceptions, the patient-reported outcome measure. The next, and allow a comparison with other institutions. And the last one is to monitor the measure indicators continuously and seek value-based remuneration that's what we practice, a clinical outcome in relation to the cost. The next. So the first action that we established to implement our ICHOM program was to visit the two very interesting hospitals. One is the Karolinska University Hospital. That was one of the first hospitals in the road to implement value-based healthcare. And also in Netherlands, we visited the Catherine Heart Center. That is very interesting because this is an international reference center in the implementation of value-based healthcare and cardiology. We visit the Cath Lab, and the Cath Lab is a partner of the ICHOM program. I show you now one of the most important studies, the trial that started at this hospital, Catarina, which Dr. Tonino is the PI. And this is one of the most important studies, clinical trials that ICHOM are involved in this hospital. So this is an interesting idea that we put some bridge using education, research, and assistance. Think the next one. Based on this idea, we want to visit these hospitals, and we have an APNI, Association of Hospitals, of Private Hospitals in Brazil. ANAP is established our journal to visit Sweden and Netherlands to know better the value-based healthcare care in these institutions in the year of 2017. The next one. After this, we start to establish our roadmap in the ICHOM program. The first one is this poster that Dr. Sheila will explain better than me, because she is one of the most important people to start and to implement ICHOM programs in Brazil, especially in stroke area. And this was very so important that at that time that Dr. Sheila was invited to present this idea in the first Congress of Private Hospitals in Brazil in 2016. But the problem, the study started 2015. Next. So in 2017, we visited the Karolinska University Hospital and Catherine Heart Center. And in the same year, 2017, we create our development managed office. And now, the next one, we are in this roadmap, we have a pleasure to communicate that we are the first hospital in Brazil to implement ICHOM strategy. The next one. So, but we have some challenges at the start of our program. And what obstacles did we find at the start? Hire a team dedicated solely to data collection in the medical records. This is an innovation program, so we have investment to create a group. The second challenge is train non-medical people for interview and different start sets. By telephone, by WhatsApp, by email, or in person. The third was create a culture among doctors. This is a very important point, to create a culture among doctors to enter questionnaire data in medical records, to establish a customization of the registration of our data. And four, know the best way to obtain patient information by email, telephone, or in person. This is the four main challenges that we find at that time. The next one, we spent more than 10 years, almost 10 years, and we have already some barriers. The first one is to establish a private data and compliance respecting the general data protection law in Brazil. This is a new discussion because we have many changes in the law recently. The second is the standardization and customization of our platform of this to establish the standard ICHOM standard sets in our platform. It's very important a part of our team of the area of the platform that we have. And the last one, I think this is maybe Mohamed will discuss better this, is be able to reconcile the interest of the hospital and health insurance companies with regard to profit margins. I think this is a great barrier nowadays, and Dr. Mohamed can explain in more details. The next one. So we are now, we are very honored to receive the invite to put our history in ICHOM New England Journal of Medicine implemental catalyst. With this history, 7 years of experience of ICHOM standard set implementation in a private hospital in Brazil, lessons learned and the future perspective from 2015 to nowadays, with more than 12,000 people included in our standard in our program, ICHOM programs. The next one. This is the history now that we are create our medical school, HMV School of Medicine, and the future that we need to discuss about the influence of ICHOM, the next one, in the future of our institution. The next two, and the last slide, I suppose, is to establish a new career for the new doctors with the idea that value-based healthcare function as a core strategy to meet the future of academic medicine. Thank you.
So thank you, Nazi. So now I will tell you how do we start this journey? We start in 2014, together with the stroke working group to build the standard sets in stroke. And you can see here with different people from different parts of the world. I was invited because of my role, not only as head of neurology in Hospital Moinhos de Vento, but also because I'm the founder and president of the Brazilian Stroke Network. And the idea is really to create a standard set that could be implemented in everywhere. So next, please, Arthur. So this standard set was created based on the patient-reported outcome and baseline measures and was presented in the World Congress of Neurology in Chile 2015. I was responsible to present this in Chile. Next, please. And was published in 2016, led by Joel Salinas and Li Xuan, but you can see in our right, different parts of the world and different specialties, including representatives of patients, but only two people from middle-income countries. So China, Professor Liping Liu, and me from Brazil. So important to know really how to implement these in lower resource settings. Next, please. So after create, that was the easiest part, was to create a standard set with baseline characteristics, also data collection during the hospitalization, and also collection after discharge. That is for the stroke, is most important in 3 months after discharge. We need to create a plan to collect the data. So we start in Moinhos de Vento data collection in 2014 as leader of neurology. So we have data collection for stroke and other pathologies, because we have neurologists in the emergency room, standardized discharge registry, electronic medical records. We create a software to collect data in a tablet, you can see here. And we start in 2015, July 2015, to collect outcome in 3 months and implement International Consortium for Health Outcomes for stroke, collecting data by mail and by phone in our hospital. Next, please. And how we did this, the neurologists include the patient, and a person in our right side collected the data from the discharge form and send an email in 3 months for the patients. If the patient did not respond, call to the patient to know the outcomes. At the same time, we start to create a model to collect in public hospital. That is a challenge, lower resource. We don't have a structure or enough people to collect. So we create teams with residents, fellows, and students to collect data at the same time in public hospital. In the same form, you can see here, very easy, you have the baseline, 24 hours, discharge, 3 months, and 1 year data collection. Next, please. Here we have more than 4,000 patients, because it started in 2014 in progress, and finished this registry in 2019, with a structured form to collect medications at discharge, adverse events, treatment used. Next, please. But really a challenge to collect all this data in different settings. So we test how to collect, because it was more comprehensive, the data collection. We using patient-reported outcomes from iTunes standard set. We create 3 strategies. In the middle, the private hospital, our hospital, Hospital Moinhos de Vento, we started sending an email with the questions to the patients after 3 months. In the public hospital, that we create another strategy, because the outpatient clinic receives 85% of patients discharged after the hospital. So the initial strategy was in person. In our hospital, no, because after discharge, the patient go to the outpatient clinic from each different doctor. It's difficult to have in-person outcomes. So we implemented also in public health system in hospitals where we have telestroke program. So our neurologists giving advice in real time for 4 public hospitals in the region. So for this, we started by calling to the patients. And the second strategy, if the first failure, call to the patients. Next, please. This we present in the first, in the annual Congress of ICHON, showing our strategies of implementation. You can see here in person, of course, as the patient go back to outpatient clinic, 10% only of missing data, by phone 21%, and by mail almost 40%, but we can see in the other side, 60% answer by mail. So we save time sending by mail or a link through WhatsApp first and use by phone as the second strategy. Next, please. So we presented this in the third ICHON Congress in London, 2016, showing our different strategies to implement ICHON in Brazil. Next, please. And it was a pleasure for us because Moinhos de Vento was presented by Caleb that introduced the meeting this year, showing hospitals that are implementing ICHON. Next, please. And you can see here was presenting this opening session in NHS. Next, please. Erasmus, next, please. Karolinska, next. Ramsay Healthcare, next. Providence, next. In Mayo Clinic, and together, next please, the first hospital implementing ICHON in Brazil, that was Hospital Moinhos de Vento, starting by stroke. Next please. So we start as an initiative of the neurology service, and after, in 2017, as Nazi showed, was created an office for really implement as institutional program. So we start before, but institutional program started in 2017. And we start to evaluate how to use this better, because the idea is to use this through the Ministry of Health to the entire country too. So comparing the outcomes through the standard set, private versus public, showing that the same team, because we have the same team working in a public university hospital and our private hospital, the same structure, same treatments, but if you can see in blue here, worse outcomes in the middle. Why? Because we have the baseline, we saw that these patients were younger, but more severe, more comorbidities, less prevention, and worse outcomes. So important to see where we need to manage. And this shows us that it's so important, primary prevention, to have this patient better and older when arrived to the hospital. Next, please. Also, we migrate to evaluate costs, and here, thanks to Ana Paula Etches, her work together with Professor Carisi and me too, moving the Brazilian ischemic stroke pathway to a value-based care, introducing a risk-adjusted cost estimate model, collecting cost with the baseline stratified in low risk, middle risk, and high risk based on age and severity of stroke, and evaluating in the process where the higher costs, depending also about the treatments used in the middle, and also the distribution in the different outcomes, showing that better patients, better outcomes, lower costs, independent of the treatment. So high cost treatments, better outcomes for the patients. Next, please, Arthur. And here the cost showing the same. Modify ranking scale 6 on the top, and 5 are death or severe disability. We have the higher cost, and you can see in categories in the lower part, ranking 5 to 6, almost $5,000, 3 to 4 better patients, $2,500, and 0 to 2 patient independent, $1,500. So showing that better outcomes, lower cost, and investing in best treatments can decrease the cost. Next, please. And we migrate, this is New England Catalyst, work from Ana Paula too, showing that we can use these together and compare different hospitals here, or Hospital View, our private hospital, and two public hospital, one university and other non-university hospital, but all the stroke centers we can compare. We can treat these patients in intensive care units, higher cost than treat these patients in the stroke unit, stimulating to create an intermediate level structure for the stroke units for these patients. Next, please. So we use all this knowledge to create a global certification program to World Stroke Organization, implemented initially in the region, in Brazil and Latin American countries, where we evaluate the hospital to certify them, evaluate the personnel, structure, protocols, treatments, and quality measurements. Outcomes of the patients should be collected. And now we migrate for next, please. The states are using the certification program to better reimbursement of the patients. So in Rio Grande do Sul, our state, because we start and we show this, only the patients from public health system only can receive the reimbursement from the Ministry of Health if they are certified and they have data collection with quality outcomes improving. Next, please. But it still is a challenge, data collection, mainly in public hospitals. So we are testing now using a structured form to evaluate the patient. When patient arrives, during the care of this patient, the doctor fill the structured form with artificial intelligence, helping us to guide through the protocol. So here a basic form with the initial assessment of this patient, after the time of arrival, collected direct from the system, time of symptoms onset, of CT scan, results of the CT scan, characteristics of the patient, and the software already say this patient is a candidate for intravenous thrombolysis. You can say, yes, you choose, I want to use alteplase. The software suggests the doses, including the bolus doses after put the weight of the patient. So the software helps the doctor, it's easy to fill, and the most important, this is integrated with the medical records, will generate the documentation in the medical records, but also generate a data bank for research and the quality indicators registry. So the patient care already generate the dashboard for quality indicators. We don't need another person to collect this basic level of data. And here at discharge is structured with everything that needs to be in the medical records, and also generate the data bank. When this patient discharge, we have a setup. This patient will receive in 3 months or wherever I want this information through a link, through WhatsApp or email, to answer how is the situation in this patient in this period. So mainly assessment to rehabilitation treatments, and also the outcomes through action outcomes, so the patient-reported outcomes after discharge. So you can see here if this patient or caregiver is filling the form, if patient lives in home or in an institution, also if was prescribed physiotherapy, if yes, if the patient assess physiotherapy in this period, and how long he wait until assess physiotherapy, the same with other treatments after discharge, and also here the outcomes that matter to the patient. Patient can walk, can go to the toilet, independent to feed, to dress, and etc. And at the end, of course, the functional outcome of this patient summarize everything to the patient, summarizing our medical records in our dashboard, and alert if the patient has some bad outcome that need to be assessed by a nurse or a nurse navigator or a patient that will evaluate the quality and aware the doctors this patient need an appointment or something like that. We are testing this, and we hope this can help us a lot, not only Moinhos de Vento, but this can be disseminated to other hospitals, including public hospitals in Brazil. Next, please, that is last one. And this generate a dashboard, and you can see here, for example, the Minister of Health can see the patients in Brazil per type of stroke, the patients in our hospital, so the hospital can compare with the Brazilian data, door to needle time, swallowing assessment, mortality, functional outcomes, and also how this patient arrived by ambulance or by family. So this is the future. We don't need to collect that, and I hope very soon we can have this integrated to our medical records and disseminate to other hospitals in Brazil. Thank you so much.
So, since 2015, we have evolved a lot here at HMV, and the VMO is actually part of a ecosystem that's composed of the clinical practice of the doctors, the research institute, and probably next year the medical school. And they all form an ecosystem of data that we can use and leverage to better the patients and do research with. So this is our team now. We got our own physical space, and we're actually in the same floor at hospital administration, so which facilitates a lot our discussions about the data and the best way to use that. And we still participate at the ANAP partnership in ISHON, and now we're 26 hospitals in Brazil that are implementing at least one ICHOM standard set. So the data collection, we still do it by phone interviews, emails, and more nowadays we use more and more automated messages. So we only call for those patients that won't answer us by other means. So we still use some key general indicators for every care pathway, as like the number of patients, retention rates, mortality, and readmission rates. And we developed a network benchmark with mean national rates that we can compare our data with other private hospitals that are part of the program. And we are still continuously using this data to improve the quality of care and develop initiatives for specific care pathways. Our timeline since 2015, we started with stroke and then heart failure and all other care pathways that developed from that. And through the years, we got over 12,000 patients included in each one of the 10 care pathways that we follow them. Here you can see the global inclusion of patients with stroke in the COVID-19 being the largest one, followed by heart failure, and then the oncologic care pathways. So we have different retention rates, one-year retention rates. It's most due by the epidemiology and the type of patients that we follow here. And here you can see for the ones that we are focusing on that our one-year retention rate has been improving over time. It's slow. It's a progress that we are still working on and developing another ways to assess these patients. But over time, we are consistently getting better at retaining these patients in all across the care pathways. The same is true for our outcomes in the clinic. Here you can see for breast cancer, And it's slow but very consistent across all the years, at least the past 5 years, that we've been each year improving the outcomes of the patients. And here is for prostate cancers, and it's pretty consistent across the years and across all the domains that they have. So we are very proud of being getting better over time, analyzing the data and getting better with that.
Okay. So, as I mentioned, I'm a cardiologist, and I'll be sharing our experience implementing the heart failure standard set. This was the first standard set that the national collaboration and decided upon, because several hospitals were more focused on the cardiology service. So we have now more than 2,000 patients being followed. And was really interesting because we have this opportunity in the cardiology department to look in a broad perspective how not only we take care of patients with clinical outcomes that really matters to physicians, but also, and more important, to hear from patients how they were feeling. Next, Arthur. So just to share some of the data that we have in the first years, looking 2019 and 2020, our length of stay was really high, more than 10 days on average for the patients, regardless of low ejection fraction, high ejection fraction. So this compare with national standards or international standards was a little bit higher than we expect. And could you please the next one? And the other important information that we are looking and analyzing was not only the mortality in the heart failure admission, but the really high and expressive 30-day hospital readmission rate. And we analyze in different formats if these were patients with low ejection fraction or high. But one interesting aspect of looking at the data at that time was that we have a very elderly population. And believe me, more than 60% of our heart failure patients, they have more than 80 years of age. So they were really old and with a lot of comorbidities. 40%, they have more than 3 comorbidities. So it was really hard to decide what we could do to improve these results and these aspects. And we look at this in a multidisciplinary team. We come up with some quality improvements program for heart failure patients. And I would like to share 3 aspects for this program. First, we look and emphasize the importance of these results and share these with the physicians. So we focus on the physicians reviewing and updating our critical pathway for heart failure patients, trying to share individual results with physicians. They have more volume or take care more of these patients, and what were our goals and recommendations to reduce this and reduce the length of stay. The second was focus on the multidisciplinary team, and we have an excellent group of nursing, physiotherapists, social service that help us a lot with weekly bedside rounds, trying to identify those patients that they stay longer than should, and they do not have adequate support to go home early. And the third aspect was to create a culture to educate patients early when they were admitted at the hospital. And this was really important to reduce our readmission rate. So can you please put the next one, Arthur? And here we have the overall results during this period of time. In red, our mortality, index mortality. In orange, we have the length of stay. The blue line is our readmission rate in 10 days. And as you can see, we have in the last 2 or 3 years better outcomes. We have lower mortality, reduced readmission rate. 2021, we have the COVID pandemic, so the results were a little confused by that. And the most probably important aspect, the cancer questionnaire. It's a questionnaire about the quality of life, how patients perceive themselves with their disease, and we have very high cancer's response or results related to patient-reported, how they feel in the last 2 years. Can you put the next one? So this is our readmission rate. You can go, I already mentioned. And I guess, I'm not so sure if Arthur mentioned, but with other standard set, the breast cancer standard set, we're able also to reduce the time between the diagnosis and the treatment. Now in the institution is around 10 days, the diagnosis and the start of first treatment in breast cancer patients. So it's really good. Next one, Arthur. And I would like to share another perspective, patient engagement. So this is the human side of all this transformation. And this is Elena. Elena is a key person, someone that she's been working, talking with patients, collecting data for very, I would say for several years now. And I guess this is important because it's another aspect of talking about collecting the patient's perspective. And she shared with us some things that she usually hear or heard in the past, that we feel that is caring attention when you reach out to us. She said the patients talk sometimes about this. You help me meet our needs and connect us to hospital service. So this is kind of feedback that validates, I guess, all the bridge, the gap that we have in clinical care and patients' experience. And in another example, she said that during the COVID pandemic, patients were really scared. They kind of run out their treatment. They did not come to chemotherapy or radiotherapy. And at that time, the role shift. They started to reassure, guide, and help patients navigate through their disease. So listening was an important tool at that time. So positive aspects from our experience: patient connection and trust, emotional support during crisis, as I mentioned, and kind of responsiveness to patients' needs. And I believe that this sometimes is the true value that we are talking about and relates to relationship with patients and the institutions. I will go through some challenges Nazi already mentioned, just to bring and highlight that everything was not only smooth. We have early challenges related to the burden of some questionnaires, so patients and even the staff struggle with the long forms. We need to individualize digital solutions. Shayla put in details how this was important, how different aspects to collect the data could change our retention rate and the results. So one size did not fit all. Some patients' phone call works fine. For others, was impossible to contact during working hours. So this is something that we need to figure out. And patients' involvement. Patients need to be, sometimes they felt overwhelmed with all these aspects, but in the end, I guess this was now a point that we already resolved. Some current challenges, data and privacy compliance. As healthcare becomes more and more complicated, we know that needs to be regulated, and legal and ethical data aspects is becoming a really concern. So we are discussing this. There is some discussion about standardization and customization of the sets. We want to have data collected in a similar way to other institutions from national and international perspective to compare our results, but sometimes we need to adapt to local and our needs. And this is something that we've been talking in a national level as well with ANAPI. One challenge, and I would say one of the greatest aspect nowadays, is demonstrate the value and the cost of all this initiative, how to translate the collected data in really clear cost benefit and clinical value to the stakeholders inside and outside, and how we can keep the support. It's very important. The other one is to integrate in clinical practice. We know that physicians, they, in a meeting, in a room, they realize this data is important, but in everyday clinical practices, sometimes they do not have time or even the workflow to look at this information and translate this in their practice in a decision-making process, for example. So we need to work a little bit more on that, how to implement this information on the day by day. And we realized that data infrastructure and integration with our medical records or even national databases would be a challenge in the future, but needs to happen. So this is just an overview. I do believe that the ISHON, in the cardiology perspective, heart failure standard said, has been a journey with innovation, human connection, as I mentioned, and organization and transformation for us. And I will lead to Mohammed to talk about the future.
Thank you, Carizi. I hope you guys hear me. I do not have any slides. They just prepared this question for me to answer. So it's a difficult question about the future. But before I talk to you guys about the future, I'd like to explain why we accepted as a C-level or board of directors accepted this challenge in a market like Brazil. So for many of you guys who have to deal with the boards of your institutions, how you guys are going to convince that this is a good project on a long-term perspective. So that's what Nazi, Sheila, Carizi, Arthur, and many others who participate on this journey with us did with me, and I did with my board. When you have a company or institution like ours who has 100 years, we have a long-term perspective, and we have to look strategically about what is good for the population. I think this should be the mission of authorities, for governments, for private sector, for public sector, for insurance companies. Unfortunately, this is not the reality that we see in Brazil and many other countries. Many institutions who take care of the health of the population do not understand the importance of data, protocols, outcomes, and prevention, and understanding about the importance of the care of the population. When we started this project in the past, first of all, I will explain a little bit about the reality of Brazil. Brazil, we have about 220 million people in Brazil. 25% of the population has a private insurance plans in different socioeconomic levels. Only 25%. So we're talking about 50 million people in Brazil only. And you have about 160, 170 million people who does not have insurance plan. So we have a universal system, medical system, like NHS in the UK. We have in Brazil for this population, for all of us. The problem is that we have underfunded budget to support the 200 million people. So we spend around 4% of the GDP with the public sector. And the private sector, which is the 25% of the population, we spend around 5% of the GDP. So we spend the same amount of the money with the private sector for 25% of the population. 75% of the population is in the public sector. People pay for insurance plans, the middle class or the higher middle class, to have the access to the private sector. Moinhos Vento is in between the private and the public sector. We are like Johns Hopkins or any other foundation. We are private, but we are non-profit or not for profit. And we are an open hospital with the physicians which are not hired by us. So you guys can imagine the challenge about being economic and sustainable, and also think about long term. The great challenge is to how can we bring the insurance companies and the authorities for them to understand the importance about ICHAN, about the value-based healthcare. They have annual contracts. So if you have a company and you hire an insurance plan, you're going to have 12 months contract. So there's no incentive about taking care in a long-term perspective. The insurance companies and also the government, they are looking to take care about the acute or the real problems from that period. And there's no incentives, even for a hospital like us, to invest on this kind of perspective. So we need leaders, medical leaders that we have here that can sit down with us and explain why it's important, not only the results of the year, but the results for 5 years, for 10 years. And also is an ethical position from our Hospital Moinhos Vento to do that. But it's important to say that we have a non-integrated system in Brazil. Even the national health system in Brazil, we don't have interoperability of data. So the person who's going, which is has a lower economic situation, he goes to a hospital in extreme situation. And nobody knows who treated him in the past. But the biggest problem in Brazil is that even in the private sector, the systems we do not know our patient as we should know. ICHON is the first step that we organize. It's a journey, as they explain in here. For 10 years ago, the first step that we did to know better our patients, to know better what happened. So we do not only follow up the protocols, but we also follow up the problems and the outcomes from the patients in different standard sets. What is the greatest challenge to us? We did that not looking for results. We have more than 40 people working on the coding. I have to tell you, Sheila, when she takes care or Carissa for heart failure or for stroke, when you have the codification of the codification of the illness, for example, for the ICD, we do not have the real code of what's happening with the patient. So we have to hire coders by ourselves, but we receive as a fee for service. So in Brazil, we still are paid by in a daily basis, and doesn't matter what are the outcomes for the patients. So we did that because we believe that the system must change. We need to go, for example, from the model from Karolinska or the other ones that we visited before, where some areas we can share the problem and the risks with the insurance companies or with the state authority, then we take care of that population and we can trust with each other. Unfortunately, nowadays, we do not have a dialogue with things are improving. We have small projects with the Ministry of Health, with some insurance companies, but we are far away from a real discussion about value. And when we talk about value, we do not have to look only for the things that we could improve. When we talk about value, you also need to look about the biggest picture. What are the things that we do better than others? So that's our biggest incentive here in Hospital Moinhos Vento, to collect the data, to start for the first steps, to start small, and keep growing and keep improving. So I have to tell you, my friends, that it's very difficult for the other 6,000 hospitals in Brazil, which have in average zero profit, to create a structure that we can analyze the data and monitor and come back to our physicians and our partners to improve better, to correct the process and the systems. But to do that, we need investments, we need support. Hospital Moinhos Vento can do that and will continue to do that, but I feel a lack of strategic perspective from the decision makers, from the government, the different governments around the world, and also from insurance companies who still are paying for the same things with different results, and are not investing or supporting the hospitals to create the real and the correct structure to analyze the data. So I would like, for example, to item that I could double the standard sets right now and triple the number of people who can support with the data, in partnership with the insurance companies, with the industry, with the government, so we can speed up, accelerate the process of knowing what we're doing right, what gold and diamonds we have in here, as Cariz and Sheila showed and Nazi showed before, and what are the things that we need to improve and correct. Because our mission here, all of us, is to save lives and take care of people, and also to improve the science and the professionals who work in our institutions. Thank you very much for Aishan for the invitation, and you guys can count on us to improve the healthcare of Brazil and from our region. Thank you.
Excellent. Well, thank you all so much for your incredible presentations. It's so fascinating to see all of the amazing work that's been done, the advancements that have been made. And personally, I loved hearing about, the impact on patients and their outcomes, but in the relationships between providers and patients. So thank you all so much for sharing that. We do have lots of great questions coming in through the Q&A. So I will start sharing some of those, and if we don't get to all of the questions today, we'll make sure to follow up via email and additional materials to make sure that all of the questions we're receiving are being covered. So first, we have a great question here that I'll pose to the group. So based on your experience, what would you say are the most effective technological tools currently available in Brazil for the practical measurement of ICHOM health outcomes? Are they solutions specifically built for the healthcare sector and the ICHOM standard sets, or are they more general purpose platforms like those used in marketing or CRM, excuse me?
Sheila, for the
Sheila,
application.
would like to-
Yes, I think I can answer. Well, the tool I show you was built for the stroke now, but they have several other protocols in development in primary care. We develop in the primary care in a program together with the World Health Organization that restructuring primary prevention in primary care, implementing HEARTS program, and we create a system also for the primary care nurse assistants, nurses, and doctors to facilitate the screening of patients, to guide them through the protocols. And this can use it, some governments are using, for example, for dengue. So this can build for different proposals, different disease, of course. So I'm trying to test the cardiovascular in primary prevention, acute care, and after discharge to try to really build that digital pathway for the patient, facilitating protocols, evidence-based guided contact with the patient, and also this connection with the patient and this support to them that don't need to be the doctor, can be a nurse navigator, for example, through the primary care or through the hospital.
But just to add, as Sheila was talking, she's really involved in this program, but there are several commercial solutions available to collect this data, not only here in Brazil, but I've heard also from Portugal, the Promptly company, the Mindfy, yes. So
Mindfy.
several, yeah. So there are
Mindfy is
some,
this one I showed.
yes, yeah.
Yeah.
But one solution, it's not perfect for everyone. So in our experience, you kind of need to have different strategies to collect this data. But I guess with AI in the future, someone asked about the AI. I guess we will turn this problem a little bit easier.
Excellent. Yeah, thank you for touching on that. I was going to follow up next to see if you've already been taking advantage and utilizing AI tools, or if you have plans to continue to do that in the future.
I would just say yes, not at this moment, but I think this will be the future, using AI at least to read medical records, to try to identify not metrics that are not standardized. So just to improve the whole process of data collection, this will be the future.
Excuse me, Carice, I do believe that we need to use AI, and that's my hope, that we can exponentially accelerate the process. The way we are using technology right now, we are growing. We're gonna grow, but not in not following the needs that we have. So AI, I have great expectation that AI it brings to us as many problems and risks, but in this perspective, AI can help us a lot to exponentially grow and give answers to value-based healthcare.
Yeah, I do believe too.
Yeah, we're actually piloting the use of AI now in the EMR to collect the baseline characteristics of the patients and the clinical data, but still not using it for PROM collection or analytics. But we're actually piloting at the EMR right now.
Excellent. Thank you all so much. That segues nicely into another question that we have here, focusing more on what is the path from measurement to actual improvement. So what is the method of improvement used? And a follow-up from that is, how do the data collection forms integrate with the rest of the clinical record? Are these forms from the record, or is it an additional element that you collect?
Do you want to answer, Carice?
Yeah, I'd say that this is a current problem or hurdle. It's a still separate or in parallel data collection. We kind of combine the electronic record with the patient's ID with this result, but it's not in the electronic medical record. So the physicians they do not have access at this time for the results that patients is giving us about the feedback. This is something that we've been talking about for a while, and we need to improve. And the other question is, I don't know, Sheila, do you have a different experience with the neurology? No.
Yeah, we are testing this system that is a Mindfy created by Mindfy and can integrate with any medical record. So in Hospital Moinhos de Vento, so Mohamed, please, because the system is ready. We need to can integrate it with any in public or private system. So will be integrated in the outcomes of the patient also in the medical record. So I think it's very important.
Yeah, but the great challenge, I'm sorry to interrupt you, Carice. But the great challenge is about technology is not the possibility of doing that. As strategically, the technology supporters or providers of Moinhos event, they understand the importance for the patient about accepting the integration with other systems. If each company wants to protect and create your own companies, we're not going to grow right now. So the providers that we have right now, we have a great challenge about integrating the data with our systems, our patient record systems. So that's a big challenge. And the projects that they have not necessarily are the projects that we need and what is better for the patient. So when we hire a system, when we contract, we need to perhaps negotiate better so it can be more flexible and more aligned with our strategic plans.
I was just addressing the other part of the questions about the quality programs. There is no magic solution. I would say the most important thing is to have the data. Once you have the data and you realize that you have a problem or something could be better, especially if you have ways to compare with other hospitals, national, international. For heart failure, as I mentioned, we realized that we have very elderly patients and we need to address that. So put everybody together and focus on the patient's perspective and what can we change. That's the key for this to go right. Not magic, not something really funny, but we need to make, in my perspective, the patient's life better. And if we focus on that they need to feel better, go smooth in their hospitalization, this is the most important thing.
I'd like to say a little words about this future, because our colleagues mentioned, but I think we need to implement another idea, that is the hospital at home. We need to maintain the connection of all the patients of our community, all time, wherever. So this we need to include in the AI perspective of our system, because the health system needs to become greater, not only at the hospital, but when they have the discharge, and all the people that around this system, it's necessary to are linked to the main institutions of health in the city. I think this is an idea that we need to go to hospital at home forever.
Excellent. Thank you all so much. I really appreciate hearing all the perspectives, and Carisi, I specifically appreciate the comment that utilizing the data to focus on the patient perspective and how those patient outcomes can be improved. Of course, that's closely aligned with the purpose of the ICHOM set. So I really appreciate that. I think we have time for just one or two more questions here. So we have one question. If you can comment on the role of competition at the regional and national levels, and whether competition was explicitly leveraged in order to actually improve outcomes.
I guess
Sorry,
this is you.
Christina, what kind of competition? It's not clear to me.
It's not explicit. It's from Geoffrey Barron. I guess outside Brazil.
It's competition about which institution are improving compared to others. I think ICHOM is a great strategy for the ones who want to lead. So for us, institutions, the 200 better institutions in the world, the university institutions, they have to force for a value-based healthcare not only a fee-for-service perspective. We need the EMRs who are not only focused on billing, on recording data for operational process. We need EMRs and medical systems who can support the physicians in the decision making. We need, Christina, someone or the insurance companies, the hospitals, the national associations, the authorities to organize the whole system. In Brazil, for example, Christina, we are very hospitality centered, and many of our patients comes to a hospital. So when you talk about value, we need more facilities for chronic patients, post-acute care patients, to take care about them in the prevention's perspective and in the day after about the hospital, from the hospital. So when we talk about competition, we talk about doing doing very well with excellence the procedures that the patients demand in that moment. But my opinion that the great institutions have to align research, technology, education, and medical practice. Also in a long term, in a patient journey, taking care about their health, taking care when they come to the hospital, and taking care after they leave the hospital. And sometimes we do not dialogue, and the industry, when you talk about the new technologies and the cost effectiveness of all the technology they're putting in the market, they go directly talk about the facilities and the new things. And sometimes we need to organize this better with data and also with ethical perspective. Otherwise, the countries like UK or US or even Brazil, it's a different problem because these countries, they have great challenge about the money that they already spend. And when you talk about Brazil, we don't have that amount of money. So when we talk about value, we need to be more cost effective, and also we need to I believe, I'm a great believer that we can improve quality, not necessarily improving investment. But for that reason, we need investment on data and people and teams and ICHM. That's why hospitals cannot do that alone. So I'm not sure if I answered the question.
Yes, fantastic. Thank you, Mohammed. Sheila, I see that you have a hand up, but unfortunately we are running out of time for Q&A. So I hope that we can follow up with you and maybe get some perspective on what you were going to share. And I know we had a couple of questions left that we didn't quite make it to. So we will be sure to follow up and make sure that those get answered. So we just have a couple of more slides to share on some additional opportunities to engage with ICHM.
Christina, thanks. I'll cover the last few slides for today, but first I just want to join what Christina said in thanking all our panelists. This was phenomenal, both in the breadth and the stamina of a hospital in sharing with us the data and the complexity of your journey. And I just want to call out Mohammed for the quote, ICHM is a great strategy for ones that want to lead. I think maybe we need to put you on our payroll for marketing taglines. But just to say that this is why ICHM exists. We were an idea that was born of needing to center data collection and understanding what is happening for the patient. And I think I've heard that throughout all the presentations and the question Q&A. And this is exactly the kind of story and evidence of ICHOM in action that we are trying to showcase as part of this webinar series. And also, as if preordained, we are going to host our next webinar with a focus from the perspective of a private insurer. Taunia is going to really talk to us about what the challenges and the perspectives are. And I hope that we can take some of the questions that were raised today about the role of insurers and payers worldwide in not only incentivizing, but investing in this journey alongside hospitals in partnership. So please do put on your calendars to join us for the next session on Thursday, the 24th of April. Go to the next slide. My last two things are to share with you that, like hospital, that we are really welcoming of all the partners all around the world. We work with academic medical institutions, industry, payers, hospitals, clinicians. We cannot do this work alone. That's how we build our the sets in collaboration with patients and with researchers and with clinicians. So we do welcome you to get to know ICHOM and find ways to work with us. And there are myriad ways that we can partner together. So this is just a few of them, and you can reach out to my colleague, Jose Delgado, to learn more. And finally, one of the things that we launched late last year was the ICHOM education program. I mentioned at the beginning that we're into the second cohort. This is a fully online program, but I wanted to draw your attention particularly because we're talking about Brazil. There is a rising demand for the course in different languages, and so we are looking to get input from you about the interest in a Portuguese version of the certificate program. So please do reach out to this email address to register your interest. I imagine there are people who are emailing as we speak. So with that, thank you to Christina for doing a wonderful job of moderating, and thank you to this wonderful panel. We are very grateful for your time and energy in presenting today's session. So good luck to all of you, and we will see you in April.